The long list on the left of this are a lot of the validated nutrition evaluation tools. At the very top, what we did is we compared the ABCD nutrition evaluation. Does it evaluate health status? Well, part of that is because we use MSQs. Does it evaluate diet intake? Yes. Does it evaluate weight and BMI? Yes. Weight change? Yes. Bioelectrical impedance analysis. How many people do BIA in the clinic here? All right, a few. Bioelectrical impedance analysis is a powerful tool for any of us in clinical medicine because it really helps us follow along with the patient what changes are happening in the course of their body composition due to our therapies or their changes in life. Physical exam and then function. There's only one evaluative tool on this whole list that clicks all the boxes. And that's the ABCDs in nutrition evaluation. You have a ABCD nutrition evaluation IFMCP guide, which is about a 40-page document in your digital folder. So you'll be able to download that. And we go into some pretty extensive description of the different tools and each step of this quick survey that we're doing today and tomorrow. It's outlined in the ABCDs and nutrition evaluation, and it starts with, it has lists to help prompt you for what are the anthropometric tests, what are the biomarkers, what are the clinical exam findings, what are the nutritional things you look at. And so that's the ABCD nutrition evaluation report. The first portion is anthropometrics, and anthropometrics is more than weight and height. Anthropometrics includes vital signs and some other functional tests. And when we're doing body composition evaluation, we're not only just, everybody does body mass index, but we're evaluating truncal obesity. We're evaluating that, whether they're gynoid or android obese, because we're looking at their waist to hip circumferences. And we talk a little bit about bioelectrical impedance analysis. And what you'll see out of this is that may be a tool that you'll probably want to bring into your clinic. The B is for biomarkers. And we organize the prompting tool and biomarkers by this proteins, fats, carbohydrates, minerals, vitamins, and phytonutrients. The biomarker list helps prompt you if you want to evaluate the nutritional status of each of these things. We organize them into 3 different tiers. Tier 1 is clinically useful, cost-effective. Tier 2 is clinically useful, less cost-effective. And Tier 3, it really helps uncover some of the unique patterns. And so the tools that you have to learn more are these very clear lists on what are the biomarkers you would use to help look under the hood of nutrition adequacy in your patient. The third area, clinical exam, we focus on 3 areas. We focus on changes in the mucosa and skin, nails and hair, senses and nerve function. With recognizing this, depending on which tissue you are looking at, it turns over at different rates. Look at, all of us have burned their tongue on hot beverages. You have altered sensation and discomfort for hours, but all of us know that it just takes a couple days for that burned tongue to restore its normal tissue, depending on the depth of the burn, right? We know the mucosa of the mouth and mucosa of the intestine has a finite period of time. The skin turns over anywhere from 28 to 42 days. The nails, fingernails and toenails turn over at a different speed. The hair during the growth phase can grow up to 2,000 days before that phase changes. We know that nails, thinking about it, can almost be like rings on a tree and tell you what has happened in the last number of days to weeks because they grow at a fairly consistent, fingernails grow at a fairly consistent rate, 0.1 millimeter per day, if you have protein adequacy. We know red cells have a different lifespan. We know lymphocytes, epidural neurons, we know neuronal lipids in the central nervous system, and calcium in the bones all turn over at a different rate. So, we use this to our advantage on the physical exam. We'll go into that a little more. The fourth area, diet and lifestyle evaluation. This is a tool we use frequently in clinic because it is a simple checklist that often can become homework for the patient, and we'll explore this in our case here. It gives you a simple way that the patient can fill out what they're eating, and also on the right for the clinician, all you have to do is look at that list, the nutritionist, health coach, or you look at that list, or your nurse look at that list and check, is there protein in what they ate? Is there essential fats? Is there complex carbohydrates? Or do they have any of the colors of the rainbow? Roy G. Biv. That's kind of like grade school. Red, orange, yellow, green, blue, purple, white, tan, brown. Do they have the colors of the rainbow? And then you can just turn that over and say, you know, when we look at this, if the vegetables and fruit are the colors of the rainbow that are highest in the minerals and vitamins, adaptogens and antioxidants in your diet, and you don't have any, and you have any of the conditions of oxidative stress, fatigue, brain fog, any of the conditions with increased oxidative stress, behavior issues, neurotransmitter imbalance, any of those conditions, we have tools in the toolbox that actually outline how these different colors of our food, how they are anti-neoplastic or heart healthy, all these things that will help you translate what you see for your patient. So these are the ABCDs. And then from that, you can transition to what might be the right nutrient plan, what might be the right lifestyle recommendations. Is it sleep? Is it ways to alleviate stress, thoughts and emotions? Is it changing their relationships? How can you take this, and that's what this ABCD Insight Nutrition Evaluative Tool package does for you, is it helps take all these considerations on the left and transition and see which food plan is best for your patient. Is it just going to the core food plan or the elimination diet that you've heard about or cardiometabolic that you'll see more tomorrow? And from this, you can affirm some of the medical histories that are associated with the different patterns. And then there's a personalized therapeutic food plan with a physician guide so you can learn more about it in one place, and then ways that you can help your patient. And part of what we really encourage, and most of the faculty here uses health coaches or nutritionists in their clinic, and it is this teamwork of the clinician, the health coach, nutritionist, or patient educator that helps bring this forward in such a way that you actually can markedly improve their health and markedly impact the progression or actually build resilience in these patients. It is looking at context, the company it keeps, the quality and quantity of the diet. Here we are, case 2. Phew, I got here. All right. I will just say that for the last 2 weeks, I was in a part of the world where it is now 1 a.m. So if I begin to slur my words or yawn a little more or something like that, just say, wake up! All right? I was down in South Africa with the other Dr. Stone, and we were giving a few conferences on developmental programming of health and disease, pregnancy through the first 1,500 days, and it was exciting, but we left Sunday, 11 a.m. Seattle time, and got in at 11 p.m. last night, and I jumped on a plane to the airport at 5 a.m. this morning, and it's 1 a.m. where I've been. So if I begin to slow down, just speed me up. That's all we have to do. So this comes back to case 2, the introduction, right? The introduction to case 2 is think about where you've been so far in the last day and a half. You've been through introduction to functional medicine, how we use the timeline in the matrix, the GI components, some of the immunity and the autoimmune component, and the elimination diet. And what we'll see in this case is the development of autoimmune response and stress, progression and dysfunction. And what we'll do is we will build over the course of the remainder of this lecture, short little caveat, and then more tomorrow, and we will see how you can go through the ABCDs in the patient. So let's learn about this 34-year-old female presented with polymyalgias, polyarthralgias. Her hands were swollen to the point of it has been being difficult to close her hands. She could not grab the brush or comb to comb her daughter's hair. She's 34. She had to use a banister to assist her to walk up the stairs because her ankles, knees, and hips hurt so much. She was developing pain in her muscles to the point that she had tender fibromyalgia trigger points. She had had Raynaud's-type symptoms, worst ever, with her hands, wrist, feet, and lower back feeling like broken bone pain. All right, Advil, Motrin, see ya. No, what's the most important thing? Ask her when she last felt healthy. When did it begin? So let's listen to this video. Hopefully the sound comes through well. Start on the click.
My girls and I were in a car wreck on November 26, 2013. Prior to that, I had never experienced an acre of pain to speak of in my life. But on that day, we had a driver pull out in front of us with a vehicle crossing a 2-lane road, and he pulled out in between cars, and I T-boned the side of his truck. My girls were in the back seat. I was in the front, and I had about a half a second to react and braced against the steering wheel. At that time, I injured my shoulder, an impingement in my shoulder, and pinched a nerve, had tingling numbness in my hand. And that's kind of how it all began.
Okay. So she was driving her car, 2 daughters were in the back. Pickup pulled out in front of her, she T-boned it. She braced herself. She had some tingling and some pain in her shoulder. So that was her trigger. So she last felt well at that trigger, before that trigger. That was 3 months before, just before Thanksgiving. She was in this MVA. She T-boned her right shoulder. She had some impingement injury. She was sent to physical therapy. Within a month, her shoulder was better, but then her joints began to hurt. What's happened? Think about that. What was her trigger? Thinking about, and then what happened physiologically to her? Over the next month, she started developing mild allergic dermatitis, worsening acne over her malar ridges. What pattern are you starting to see? Female, 30s, rash, malar ridges, joint pain. Lupus is what you're thinking about. Then, a month and a half ago, before she presented, she developed increased muscle and joint pain, gradually increasing muscle spasms. Then she had this progression, and she was explaining it away as she was just getting older. Then she started having increased Raynaud's. Then she started having increased blurred vision in her left eye. So you see the sequence that began. So her past history, no known drug allergy. She'd been using some ibuprofen. She had used some minocycline in her past for her acne. You ask your question, is this a minocycline-associated lupus? Well, she'd been doing this for a while. Was it triggered in the setting of her stress? Good question. She is using some vitamin D supplementation, some probiotics. She's married. She's happy. She works in a family business, a bookkeeper. She's never smoked. She drinks a little wine, 4 glasses a week, which increases LPS, increases gut permeability, right? She has a family history, father with ulcerative colitis, mother with arthralgias, and always dry. Past surgical history associated with C-sections, repeat C-sections, and varicose vein surgery. Notice some of the complications in her pregnancy there, though. Did she have an upregulated immune system anyway? With the periodic urticarial papules and plaques of pregnancy that had to be used. They had to use dandelion root and prednisone to get control. Did she have an upregulated immune system already? Her past medical history is noted here. Antibiotics 4 times in her first couple of years. She had recurrent sinusitis 2 to 15 years, 2 times a year antibiotics. Frequently, she had chicken pox at age 7. It continues. You can see she had migraines, dysmenorrhea, pustular acne at age 31. Unique. Still sinusitis. Anemia, fatigue, varicose veins at 31. Nodular acne and vitamin D deficiency at 32. So what pattern do you begin to see that may have been a setup for her acute change? What did she eat? Let's just use her basic food form. This is how her day goes. Start looking at this diet. Does she have a lot of color? Does she have a lot of antioxidants? You can use and we know that the color, antioxidants, essential fatty acids, adequate magnesium, adequate vitamin A, adequate vitamin D, adequate probiotics, all help maintain mucosal lining integrity. Knowing what you've known so far, does she have much of that in her diet? So, just glancing at this diet, does she have much color? A little bit. Does she have much essential fats? Not so much. Does she have adequacy of protein? Maybe. Is her diet, does she have the quality and quantity of diet to bring immune balance? So, when you look at this timeline, what are the patterns that you see? What I'd like you to do is, for just even 3 minutes or so, just discuss what you see on this timeline. So here's a person, I was healthy until this happened. Was she, through the functional medicine lens, healthy, or was she trying to bring balance? And from the very beginning, with the multiple infections, antibiotic use, was her microbiome always challenged through the course of her life? And you might say yes. And was the setup, was she in a good immune balance, an optimal nutrient balance for immune balance before this trigger? Well, she was vitamin D deficient. She had been treated for a long time for acne, cystic acne, and what we'll see tomorrow and what many of you know is that if somebody has acne at an age that is inconsistent with the normal time acne occurs, meaning in teenage years, you have to start thinking about inadequacy of essential fatty acids or imbalance of the gut microbiome, and because there is a gut, skin, brain connection. Increased stress. Is there adequacy of sleep? What are the stresses of the life? How does that affect the microbiome in the setting of nutrition? Adequacy or inadequacy? So we were all seeing she has this antecedents of autoimmunity. She had a lot of triggering events through the course of her life, and she had a lot of the signs and symptoms of immune imbalance that has progressed even from a very young age. She had the vitamin D deficiency, as noted, and so even though she was healthy, she had a terrain that suggested her immune system was always trying to catch up and was actually on a little bit of hyper alert, if you wish. You look at all the things you learned about intestinal permeability, and she had a lot of things that made intestinal permeability increase, including after the MVA. She was on ibuprofen to try to deal with her pain. She continued to have wine. And if you want to induce increased gut permeability in a research setting, all you have to do is add one drink with alcohol, and you increase the gap junction width, you markedly increase lipopolysaccharide levels in the serum, and now you're off to the races. So when you look at this in the setting of her diet, which didn't have that much color, she had some, you could almost begin to outline the story of this immune imbalance. And in that setting, what's your next step? Your next step, we will see in about 15 minutes, is to order and look at biomarkers in that setting and see where she is and how you might bring balance. So that's the setup. Now we're going to go through the A and the B of nutrition evaluation, and we will pepper in more details about her case. And by the end of tomorrow's morning lecture, in which you're all going to come with feet that you can take your socks and shoes off, you'll be given tuning forks. The first thing, well, let's practice this. This is to get you ready for tomorrow. Can you look at your neighbor and stick out your tongue? Go ahead. Look at your neighbor and just stick out your tongue. No, you got to stick out. What do you see? Now, this is one of the only conferences that we'll encourage people sticking out their tongues at each other, and we'll do more of that tomorrow. And you'll look at your fingernails, and you'll check the vibratory sense and monofilament on the person sitting next to you.